thank you team for taking the opportunity to join us today. From the registrations, I can see we should have doctors joining us from north as Mackay in Queensland and as south as Devonport and Hobart in Tasmania. And we obviously have a strong South Australian presence that'll be joining us as well. Today we're going to discuss procedural work in general practice and in particular associated medical legal risk and how you can reduce your risk. For those of you that don't know my background, I completed a Masters of Medicine in Skin Cancer through the University of Queensland. And I've worked and practiced in skin cancer clinics in Tasmania, Queensland and South Australia. I also do general practice work. But we're also fortunate today to be joined by Marianna Kelly. She's an Avant risk advisor, so we can get a clear perspective from a medical defence organisation on risk reduction in this area. Marianna has been in the medical industry in varying roles for the last 35 years, and she has a postgraduate training in risk management and is a senior risk advisor at Avant. And Avant Mutual are the largest medical indemnity provider in Australia. Over the session, we'll address these main areas: the consent process, skin cancer procedures and risk, scope of practice, and then we'll run through some case studies and questions. At the end, we should have plenty of time for questions, but at any stage you want to ask a question, just chuck it into the chat box. And Colin is here helping me, and we'll jump on that chat box and let me know there's a question popped up that we might be able to address. I'll ask everyone else to mute their Zoom attendants, apart from Marianna, so that Marianna can jump in at any time too and have a chat. But if you've got a question, just put it on the chat box or raise your hand and we'll see if we can get to it as soon as we can. The entire session should run for about 60 minutes, so we won't keep you all night. So to get started, gaining adequate consent is vital in any medical procedure. Similar to examining a patient, you must have the permission before you touch their skin. The RSCGP has created and has great framework around what constitutes valid consent. And for it to be valid, it needs to be provided voluntarily by the patient. They need to be lawfully competent to do so. And they need to be given sufficient information so they can evaluate the benefits and associated risks before providing their informed consent. Consent can only be given with the understanding of the material risks involved in the proposed procedure or treatment. So what are the material risks? Well, they are the risks that a reasonable person, if warned of the risk, is likely to attach a significance to it. For example, if death was a risk in any procedure, that'd be a material risk. Or if the medical practitioner is or should reasonably be aware that the particular patient, if warned of the risk, will be likely to attach significance to it. So that'd be like loss of vision in a patient that is a graphic designer, where losing their vision would be considered a material risk. Now, these material risks may vary from patient to patient as well, so we'll just take a closer look at that too. So for example, cryotherapy has material risks. So it's important to advise the patient about rare complications. For example, damage to digital nerves in the fingers or damage to the flexor tendons on the fingers, which was first reported in 1989 with the use of cryotherapy. Biopsy techniques also have material risks, and they're often location specific, but include damage to underlying superficial nerves, especially those outlined in the slide, like the temporal branch of the facial nerve, and the palsy that will follow on the face if damaged. Material risks of excisions include scarring. This is unavoidable, but is often unpredictable. But obviously keloid scarring is the most significant, and the patient has a right to be warned of this possibility. Some material risks are patient specific. So the site of the procedure may increase the risk of damage to important structures, like the tear duct if you're operating near an eyelid or a tear duct. The patient's comorbidities may increase the risk of complications such as wound infections or dehiscence, and needs to be considered as a material risk. For example, a patient that's diabetic with peripheral vascular disease, they might have a superficial basal carcinoma on their lower leg. So they need to be advised that this location to them is considered very high risk for poor healing, for secondary infections and wound complications before the procedure is performed. So they would all be considered material risks for a patient with diabetes and peripheral vascular disease. All procedures should have an adequate consent form, and that's where you can document the risks clearly for the patients. Doctors that are accredited with the Skin Cancer College of Australia have access to their consent forms, but all consent forms have cover the same material. This is the one that I currently use in my clinics. The top of the page outlines the condition, the procedure to be performed, and the specific site where the procedure will be performed. It then addresses the risks. These are both general and material, but it needs to be specific to the patient, location, and procedure. So I use the other area, which is down the bottom of the page, to document any particular material risks I consider important for the patient undergoing the procedure. Then there is the patient acknowledgement section, where it outlines that they have discussed treatment options, the risks involved. It always includes offering a referral to another specialist and the ability for them to ask questions and that we've addressed their concerns adequately.
Jarrod, can I also add there that it is really useful to include the use of tick boxes, which may, documents any diagrams you may have used, tools that you may have used during the consent discussion, any handouts provided to the patient, including post-procedural instructions provided, and also include an open field which will document if the patient has expressed any specific concerns.
Yep. So they're all important factors. I should probably add to this one. I think that's very reasonable.
Is that the Australian?
No, the Australian skin cancer one's a bit different. Okay. I actually prefer this one. The next important thing, once you've completed this document, is that it has to be scanned into the notes. So, if a claim ever comes about, you have the ability to access the procedure consent form. You can talk about the risks that you were discussed, and you've got proof that they signed the consent form. Obtaining patient consent is both essential to good medical practice and obviously a legal necessity. To reduce your medical legal risk, I would encourage you all to obtain valid consents for all the procedures listed below. Even some topical therapies that have high risk for leaving permanent pigmentation changes are worth documenting appropriate consent. Time and time again, the Professional Services Review Committee report a lack of valid consent when auditing GPs for skin cancer work. So my advice would be try to gain consent for any sort of procedure you're doing, but also some of those topical therapies.
Joe, we just had a question around those particular nerves and just what's the worst case scenario if those nerves are damaged, and should that be on the consent form?
Oh, I think if you're going and you're doing procedures, sorry, we just had a question, so we're just jumping back. If you're doing procedures next to what are called the tiger zones, they're the superficial branches of particular nerves that supply and obviously perform a variety of function. You'd only advise them if you're working in those areas that damage to this nerve could result in this complication. The patient has to be aware in those areas that there's an increased risk because that nerve runs quite superficial. All these nerves are available in textbooks, but if you're working in skin cancer, these are the four you need to be aware of because they do run very superficial. Hopefully that addresses the question. Try to use procedural specific consent forms. So the process of gaining consent needs to be robust to reduce your medical legal risk, and it really needs to address these points as well. You need to give time for the patient to understand the risks versus the benefits, as well as alternative options. You should try to give a cooling off period so the patient has time to process the actual procedure and the treatment you're going to perform. So as a general rule, I see a patient for a skin check, advise that they've got a problem. I'll get them back on a following, and then I'll go through the consent process there. They'll take information home with them. They'll come back another day to have the procedure done. That way they've got the time to process what we've talked about, and then they may even come back with more questions. But that time aspect is really what the Professional Services Review Committee is looking for, that you're giving an opportunity to think about the options that they've got, the risks involved with them, and like a cooling off period before you do the procedure itself.
Sorry, you're right. At Avant, we will often use the expression consent is not the form, it is the actual informed consent process, so the discussion, etc., as you've been talking about.
Yep.
And I've probably jumped in there, and I'll go on. You continue, and I will add something after.
No, I was just going to say this has actually become quite topical recently with Dr. Teo, the neurosurgeon, being quite prominent in the media. And, you know, in fact, he's now got to get a second opinion from other neurosurgeons before he does some procedures himself. So this is the whole aspect of, you know, only doing evidence-based medicine, giving the patient all the options, all the risks, and giving them time to process it.
And it is also worth noting that our Medicare Special Counsel at Avant has been informing all of us and is quite strong in this point, that the PSR, Director of PSR, is now stating that consent for minor procedures should not only be recorded in every case, but that it be of a standard similar to that you would expect to see for a procedure carried out in a public hospital, which I thought was a pretty strong statement. So it is really reinforcing the importance of the consent process and the documentation of same.
Yeah, and I know, Marianna, you and I have talked about it before, but Queensland Health have a very good consent form as well.
Yeah, yes.
I think it's available on the net. You can download it. That's a very good consent form too. So patients have the right to information and to be actively involved in decisions affecting their health and well-being. Verbal consent is really only adequate in really small, minor things. So giving a vaccination, or, you know, if someone walked in and they've fallen over and lacerated their leg, then closing that wound with sutures, that a verbal consent for that would be adequate. But if you're considering any bigger procedures, then you definitely need a process and the written consent and the cooling off period. The ability for the patient to really digest the information is really the key aspect of reducing the risk when it comes to medical legal claims against you. So that may even involve returning for a second consult just to finalise that consent process. The other aspect of consent to consider is that it always includes financial consent. So you have to give the patient a guide on what, you know, the gap or the private fee for the procedure may be. So they've got an idea of the expected out-of-pocket costs with any work to do. It's crucial that the information you provide is appropriate to the patient's circumstances, to their cultural beliefs, to their expectations. It's really important you address their fears. It's just as important that the documents are all signed in and added to the patient's file. Stevenson reviewed the sources of medical legal complaints against dermatologists in Australia over a 3-year period. And their research showed that the vast majority of medical legal claims against dermatologists were patient expectations were not met, and that was 31% of the time, and adverse outcomes from the procedures, which was 29% of the claims. So I'm not saying that we're dermatologists, but as GPs and skin cancer doctors, we do perform similar procedures in our rooms. And so I would expect a similar medical legal profile. I think it really just demonstrates the importance of communication with the patients and the consent process. As often as our medical legal risk can be reduced by having clear communication on expectations of the procedure, that's really important. Avant was able to give me a few more statistics related to medical legal claims. And so 1 in 10 Avant GPs had a complaint made against them in 2019. So that's quite a profound number of GPs that are having complaints made against them. Doctors sometimes have allegations made against them, even though they've provided adequate care. And that really comes down to when a patient's expectation hasn't been met, even though you've made, you know, the right choices and you've provided the adequate care, these claims can still be made against you. 57% of all complaints came from the regulatory complaints. So that's from the Health Ombudsman or the Health Commission or APRA, depending on your state and where you're working and who's looking into that. 6% of all claims related to procedures, 13% to management treatment options, and 23% to both diagnosis and practitioner behaviours. I think often the diagnosis aspect is sort of a delay in diagnosis or a misdiagnosis, but it can also be the misinterpretation of the pathology report, like not acting on perineal invasion, if they mentioned that in the report. So if you want to reduce your risk, you make sure you read the pathology reports really well.
And I think the communication and consent failure, according to the data that we've collected, often relates to the consent process being paternalistic rather than including shared decision-making as part of the process. And I think also worth mentioning here, even well, it is about consent as well in a different way, is that many of our claims also with skin related procedures, and this has involved some dermatologists as well, is the allegation of inappropriate touching, not having a chaperone present, information not being provided to the patient prior to the examination that they would be expected to undress. And most of us would think, well, why would a patient be presenting for a full skin check if they didn't think they're going to be undressed? But it's really interesting that some of our claims that have actually resulted in quite a long period of investigations against that doctor has resulted from lack of information being provided to the patient about how that examination will be conducted. And there have been a few claims where and I can remember one in particular where a dermatologist had been seeing the patient, he'd seen her before. She presented the next time for a full skin check. He proceeded to examine underneath her bra and underneath her underwear. And she then complained to APRA saying that he was inappropriate. And again, that came down to communication because he didn't reinforce to her why he was doing it, didn't prepare her beforehand about what to expect.
Yeah, thanks for that, Marianna. With respect to procedures we perform, the vast majority of our medical legal risk can be broken down into these categories. So we'll just take a closer look at these topics. We've already covered consent, so we can move on to procedure-related complaints. The greatest medical legal risk to us during a procedure is damaging underlying structures, leading to patient comorbidities. Along those lines is not meeting patient expectations. So this could be related to cosmetic results, or it could even be related to the procedure itself. Underestimating the bleeding risk at the time of the procedure or ongoing bleeding post-procedure. Post-procedural complications also open skin cancer doctors to medical legal risk, which includes surgical site infections, wound breakdown or dehiscence, unattractive scarring like keloid scars. And although patients should be informed about all the above risks, if their expectations are not met, then as mentioned before, even doctors that sometimes have allegations made against them, even though they provided adequate care. So it all falls back on that communication, like Marianna's saying, and the consent process, making it really clear what's going to happen, what the ramifications are. You definitely will end up with a scar. There's no scarless skin cancer surgery. Medical legal risk is also related to appropriate follow-up and ongoing referrals. So first of all, we need to make sure that the pathology report clearly documents that we have adequate margins when excising skin cancer. If you fail to recall a patient when a skin cancer has not been adequately excised, you're opening yourself up for medical legal risk. So again, just make sure you're really reading that pathology report appropriately. Likewise, if the pathology report acknowledges that there is perineal or perivascular invasion by the skin cancer, then it should often lead to referral to a specialist for further management. You also need an appropriate recall system so that the patients that have had skin cancer excised are followed up for their local and regional recurrence. This is especially important for melanoma patients, where we all know the greatest risk for recurrence is in that first 5 years post-excision. So my melanoma recall would be 3 months for the first 2 years, and 6 monthly for 2 years, and out to annually. But the key thing is to make sure you've got a recall system, because you can have medical legal claims made against you if you fail to follow up skin cancer you've excised.
And Jarrod, on that point, it's often worthwhile if you're going to the extra process of sending a registered letter when that patient has remained non-compliant after, say, the third contact, of including in that registered letter written information about the risks of that patient not complying with that follow-up. We've found over the years that the doctors are going to, and the practices are going to, a lot of extra effort to send these registered letters when the patient is non-compliant, but to actually put that extra information about these are the risks to you if you don't follow up with this, because some of the case law has shown where the judges will make a statement that you cannot expect the patient to have the clinical understanding as a doctor would.
Yeah, Yep, that's a very good point. One of the easiest way to reduce your medical legal risk is to know when to refer a patient on to, other specialists for ongoing care or treatment. The yellow box there on the right, they're the recommendations from the Cancer Council Australia's clinical practice guidelines for keratinocyte cancer, which were updated in 2019. I think if we're all working in skin cancer, then we should be really aware of the guidelines that are out there currently. They provide sort of the evidence-based aspect of skin cancer management in Australia. So if you're not yet, make sure you are very familiar with the keratinocytic cancer guidelines, but also the melanoma guidelines in Australia. But as a general rule, you will reduce your medical legal risk if you follow them closely and refer patients that match those criteria, and especially patients that have skin cancer in high-risk areas. So the Professional Services Review Committee also encourage feedback from a skin cancer doctor to their normal treating doctor. And so this is especially important if you're at a standalone skin cancer clinic and work off a separate patient management software system compared to the normal treating doctor. The Professional Services Review Committee, they expect transfer of information back to the treating doctor for appropriate continuation of care. So Avant have given me a little letter that they use for patients to sign, just outlining that they give consent for the communication back to the regular doctor, or if they decline to give consent, then that's the bottom section of the paper there. Now, you don't have to use the Avant, but it's 100% worth having one in your patient management software so that you do address that continuation of care if you're working in a standalone skin cancer clinic.
And it's also worth noting that if you are referring to somebody else, to actually document in the file, in the patient's record, that the discussion about the importance of attending was addressed, because quite often in some of the claims, the lawyers will say, so what information did you provide the patient? And the doctor will say, it was standard. It's standard for me to always explain the risks of attending the referred appointment and the benefits. And, the old saying, if it wasn't written, it didn't happen. So we often encourage our doctors to develop a macro shortcut, 4 keystrokes RBRE. We'll throw into the documentation the risks and benefits of attending the referred appointment have been explained to the patient. Some of the plaintiff lawyers will say they don't like these macros or shortcuts because they say, doctors, and some do, unfortunately, will copy and paste and just keep using the same thing, even though it may not have been addressed. But we would encourage you to use macros and shortcuts, but personalize it to that patient. Yep. So if it was somebody who was at the risk of melanoma, you would just add a few notations after that, specific to that patient. Yeah.
And I think the key there is also don't be afraid of sharing your patient. I have a few patients who have had melanomas, they've got dysplastic nevi syndrome. I share them all the time with dermatologists, so that you've got a second pair of eyes looking at those patients. What we haven't addressed so far is scope of practice, and it's vital in general practice to manage patients within your scope of practice. Medical indemnity insurance will not cover you if you work outside your scope of practice. All the medical indemnity providers have the same exclusion clause, which just outlines that if you're working outside your level of training or your level of experience, then you will be excluded from cover. So even though you may have picked a policy that covers you for particular procedures, if you don't have the adequate training or experience in those procedures, the key is your medical insurance can choose not to cover you. Would you agree with that, Marianna?
Oh, absolutely. It would be seen outside of the scope of practice, and it's not under the cover, within the cover.
Yeah. How's your chat going? Any questions there?
It's a difficult one, isn't it? Because what recognised training is a very broad term. But I guess it's being, if you feel Marianna, what do they mean by recognised training? Is that justifying your experience, or is there, depending on the specific skin cancer, are there sort of recognised training?
Yes, Jarrod is going to address that in a few slides onwards. Should we leave it for there?
Yeah, absolutely.
I've just sort of addressed it here. So what is considered adequate training is $1 million question. And unfortunately, there's no definitive definition. However, if recognised adequate training in the event of an APRA complaint will be determined by your peers. So I'll give you 3 examples. And just ponder what you would consider adequate training for a simple excision, maybe a more complex excision, and then flaps and grafts. So when a doctor is investigated by APRA in response to a patient complaint related to skin excisions, the medical board doesn't often criticise a doctor relating to the scope of practice when they're performing small excisions. The medical board are more concerned about bad outcomes and investigate whether the procedure should have been performed differently or where patients' consent was adequate. So if I was part of a professional review by APRA and asked to assess someone's level of training, I would probably be looking at example 3 as being adequate for more complex procedures like grafts and flaps. So to me, you're 100% you have to be a fellow. You need to have done some sort of advanced surgical training. You probably should have done a mentorship with some skin cancer practitioner or assisted a plastic surgeon privately for a while. So you get really familiar with grafts and flaps and the complications from such and expected healing and what it should look like. I think if you've just done a weekend course, you are potentially just opening yourself up to that medical legal risk claim and potentially not being covered by your medical indemnity insurer. The Skin Cancer College of Australia has published its scope of practice documents, and this is what this is. The key points here are that you still need to know your limitations, you need to work within your scope of practice, and you need to refer more complex skin cancer to appropriate specialists or skin cancer doctors that have appropriate training. Unfortunately, this training also must be recognised in Australia. So even though some of our doctors may have a wealth of experience in surgery overseas, if the qualifications are not recognised in Australia, then they also are potentially working outside their scope of practice. The Medical Board of Australia also touches on scope of practice. And again, the key thing there is you must be trained, qualified and competent. And if you're extending your scope of practice to an area that your peers might reasonably expect from a practitioner in your field, you're required to undertake any training that peers would expect before taking up the new area of practice. So if you're furthering your skin cancer work into more advanced procedures, that's sort of saying you need to have training that your peers would expect you to have as you carry out those procedures. So let's have a quick look at insurance and categories. All insurance companies have sections dedicated to various scopes of practice. The key thing is to make sure you are covered for the procedures you are performing. So Avant has 3 categories, and that's general practice non-procedural, general practice standard procedural, and then general practice non-standard procedural. These just increase based on the more advanced techniques you're performing. But the key thing there is if more than 25% of your billings are from skin cancer work, then you need at least the general practice standard procedural coverage. Some providers also change their categories based on the location of the procedures you're performing. So some medical indemnity providers will cover you for face versus non-face, and they'll be in different categories. The real key element there to reduce your risk is that if you don't know if you're currently covered appropriately, make sure you send your medical indemnity an email and just outline the procedures you're doing, telling them how often you're doing the procedures and are you covered for those procedures. I think it's the easiest and clearest way to get an idea whether you're covered for those procedures as you move forward. So the fundamental safe practice points for working in skin cancer are to use treatments that are only evidence-based, use drugs and prosthetics that are approved by the TGA, undertake adequate training and mentorship in new treatments, make sure you have adequate insurance coverage, make sure you're working within your approved scope of practice, ensure that your institution's facilities resources are appropriate, use an adequate consent process, including informing your patients that the procedure is new and may have risks that are not yet known if you're performing any new procedures, and audit your outcomes. Communication remains the key with respect to management of patient expectations. If their expectations are high, consider referral to a plastic surgeon. To me, that's a red flag to start off with. Also, patient expectations can also be affected by the cost of the procedure. As a general rule, you can expect the greater your gap in doing these procedures, the greater the patient expectation is in terms of cosmetic outcomes. So just be mindful of that when you're setting your practice prices. Self-audits are going to become more common when we move to the next training and to the changes in the CPD that's been announced recently. But they still have a role now. So if you start a new procedure or notice a higher complication rate than someone else, I should suggest you start a self-audit and compare yourself to your peers. So the self-audit could look at how often your margins are adequate. How often do you need to do a repeat surgery to remove the same skin cancer? How often you get recurrence in a particular field? How often your wounds break down and how often you get post-surgical site infections? In the event of a professional service review, it's these self-audits that actually hold you in good stead. Regular clinical meetings in the practice and the sites also give the opportunity for staff to discuss possible audits. It's also sort of a safe environment where we encourage that dialogue between any team member. So if a team member has concerns about particular procedures or have noticed particular outcomes, that they can be raised at a clinical meeting, and then maybe you all work towards a self-audit in that area.
Jarrod, I think you made a really good point about revisionary procedures. If the outcome hasn't been what you would expect or what the patient would expect, we would really strongly recommend to our doctors that they are not the ones to do that revisionary procedure, that they actually are referred on. Yeah. I mean, that makes sense to me too.
Can I tell where do you get them? You mentioned the benchmarking of accepted standards. Where would you go to get that information?
You could, well, the guidelines, the clinical cancer guidelines for previous cancers talk about, margins, particularly in terms of what margins you need and adequate margins. It's known that 3% of any skin procedure can get a skin infection. Yeah. So if your infection rate's greater than that 3%, then I'd be looking at doing a self-audit on those sort of things. And then you're talking about your peers. So if you're working in a dedicated skin cancer clinic, everyone knows sort of the rates of infections they're all getting. They should all be very similar. Same with flap or graft breakdown. There's expected flap and graft breakdown, but if yours are higher than someone else's, then that's to me suggesting you probably should audit what's going on. So this is just an example of the Professional Services Review Director Report. These are published monthly, and here they assessed a skin cancer practitioner, and they were probably audited due to the volume of the Medicare claiming, as they were sort of billing 99% greater than their peers. Now, peers for a skin cancer practitioner are still, unfortunately, all GPs in Australia. They're not dedicated skin cancer practitioners. You are compared against all GPs. They were assessed here for item 23, some of the wound repair item numbers, and some non-malignant excisions from the face and lower limbs and distal limbs, and also for flaps. The biggest red flags I've highlighted there in red, it was just often charging a level B with routine aftercare. So the Professional Services Review Committee don't like to see that. And you need to just justify in your notes if it's not normal aftercare and the reasons why it's not normal aftercare. There was inadequate record keeping. Often the MBS item numbers descriptions were not met. Patient consent was not documented. And not all services were clinically indicated. And I think that's also a critical point, that you need to select your procedure based on clinical need rather than Medicare item numbers that are available to you. So this GP was found guilty. He had to repay $50,000, but he was also disqualified from accessing Medicare benefits for the following 3 years, which also is a relatively big red flag to me that this is quite a significant event. To be disqualified for 3 years is definitely a significant event. So we'll start looking at some examples now. So several serious patient complaints relate to pain and scarring associated with cryotherapy. So you will reduce your risk of medical legal complaints if you use cryotherapy appropriately. And just to be clear, I'm talking about liquid nitrogen here as the form of cryotherapy. Cryotherapy is not recommended for high-site facial lesions, such as the lips or the alar creases, or the inner canthi or the periauricular regions, because it achieves lower cure rates. Among its concerns were complaints about doctors performing freeze-thaw cycles that were inappropriate in length and frequency, as well as patients not being informed about the associated risks, such as the pain and the ulceration and the scarring, as well as addressing alternative options to them. So in general practice, we use liquid nitrogen for a number of reasons, but mainly it's to treat solar keratosis, and if not, it's to treat verruca or viral warts. And so you need to discuss, again, the material risks associated with using liquid nitrogen, which would be digital nerve damage, ulceration of the skin, pain of the procedure, but you also get frostbite and necrosis if you perform it for too long. I think it's important to realise that the depth of the freeze will roughly be about 1.5 times the radius of the ice ball. And the guidelines are that for warts, about a 10-second freeze, for plantar warts, about a 10 to 20-second freeze, and for solar keratosis, about a 10-second freeze max. And my advice with liquid nitrogen is go lightly and get them back more frequently, so you review those areas. So you do it once, you get it back in 2 weeks, and you review what it looks like.
Or numeracy skills just find extended.
Let's have a look at punch biopsies. So this is a punch biopsy of the ear. My advice would be to pick your biopsy technique based on the pathology you're expecting. So if it's an epidermal issue, just make sure you do a little shave biopsy. You'll get the diagnosis from a little shave if you consider it an epidermal issue, more than you need the punch for it in sort of in that area. Your consent here has to be very robust. Did you advise them that there was a risk of an ear piercing with a punch biopsy? So just make sure that your consent form is very robust.
From non-English speaking backgrounds, and the schools embraced back to basics teaching.
Next, I might just ask everyone to mute theirs. There's just a bit of feedback there. With these next few cases, just consider the aspects outlined in the box on the right, which relate to what would be considered if an APRA complaint was made for these procedures. So, should I be doing this wedge resection for a proven SCC of 2 millimeters on the ear? You know, this is a high-risk location. There's a greater chance of recurrence. There's a greater chance of poor cosmetic outcome. Just consider what training your peers would consider appropriate for you to be performing these procedures if you did end up with an APRA complaint. How many of these do you do a year? How can you defend this in court? Have I let my medical defence know that I do these procedures? I think those are the things you need to be addressing here. What's your plan if your margins aren't clear? Before you do any procedure, I generally think about my plan if my margins aren't clear. Shave biopsy. This is a common procedure. You may do 10 of these a day, 20 of these a day. Always consider, have you gained adequate consent? Does the patient know the risk? Do they appreciate there will be scarring? They also need to know that there is necessity for a second procedure if it comes back as skin cancer. Have you explained this to them? Are they aware of the financial costs of this procedure and the subsequent procedure? This is a simple excision. Most insurance companies will cover all GPs for simple excisions. But this is a young patient. They have a basal cell carcinoma on their nose. Are they aware of all the risks associated with that procedure? Again, what are you going to do if the pathology comes back saying that your margin, your peripheral margin's not clear? The patient's expectations here will be high on a cosmetic result because it's a cosmetically sensitive area. It's also a high risk for recurrence, being the H aspect of the face. So once again, my skin practice, I'd consider referring that off. But we're all different. We all have different skill sets. I see this one a lot. This is a H flap on the forehead. Again, it's a young patient. It's a large lesion. Its diameter is greater than 30 millimeters. We can all generally do this procedure, but again, we just need to question whether this should be done in general practice. Have you let your medical indemnity know that you're doing these procedures? What recognised training would your peers expect for you to be doing those procedures in general practice? You definitely need a robust consent procedure, because again, the patient expectation is going to be quite high. It's a cosmetically sensitive area. And just again, consider what would you do if your margins weren't clear? This patient may need a lesion removed from their shoulder. You know, they've got a history of keloid scarring. The risk of keloid scarring in this patient is going to be greater than other people. What if the lesion was on their face? You know, there's still a risk of keloid scarring on the face. So to me, keloid scarring by themselves is a bit of a red flag. That the patient 100% has to be aware that scarring here is very unpredictable. And if they're really worried about scarring, I'd be consider referring that on as well. Rotational flaps on the nose. Again, this one had a great cosmetic outcome, but you really want to make sure the consent process outlines exactly what the risks are to this patient. What if there was flap failure? What would the cosmetic result be if there was flap failure? What if the margin was involved? How would you fix that problem? So all these things need to be addressed with the patient before you go through the procedure. But again, I'd be erring towards refer these off. It's not worth your risk. This is just a simple excision on the lower leg, but the leg's bare of hair. So I'd suggest this patient probably has peripheral vascular disease, which makes it a higher risk location. You're going to end up with a relatively large wound, which is going to take longer to heal being on the lower leg. So these are all material risks that you need to advise this patient about. What if the pathology of that showed it was just a squamous cell carcinoma in situ, which is an epidermal problem? Do we need such an aggressive excision to remove that problem? I think that's where you have to be really discussing the alternative treatment options that are available to that person. Now, I know that I don't think many of our clinics do photodynamic therapy, but it is quite common in skin cancer clinics to do photodynamic therapy. I think the biggest issue with it is that you can get permanent pigmentation changes in people in the treatment field. So patients have to be aware that there is a risk of these permanent pigmentation changes. It's often quite painful. It'll blister, it'll peel, they can get skin infections. The treatment area needs monitoring over a long period of time. So these are all the things that need to be advising the patient before you do a procedure like this. And this is the final slide before we move on to questions, but it's all about scope and practice. I can do a punch biopsy, but does that mean I should be punch biopsying the tongue? And to me, if you work within your scope of practice, you reduce your medical legal risk significantly. Any questions? I don't mind if you use the chat or whether you open up your mic now.
Yeah, I think I'll mute.
Jarrod, whilst we're waiting for questions, I wonder whether it's worthwhile discussing the issue of clinical photography, whether it's well utilised in the practices, and if it is, one of the issues that we find is that many of the GPs will store that clinical photography on their own laptops. It's not on the central patient record, so nobody else can see it. If there is a claim, sometimes the backups haven't been appropriate and that information is missing, which will help to defend a claim. So it's just, and I know some doctors don't like using it at all, but it's just worth mentioning about if you are using it, how it will be stored, that other doctors in the practice will have access to that information.
Yeah, so most of our clinics now are starting to use a platform called Derm Engine, which is a cloud-based platform.
That's good.
And the photos, they're stored securely on that Derm Engine platform, but you can actually download a PDF back to the patient's correspondence. And so whenever I use it to take a digital photo, I download the correspondence directly to the patient's file, so it's in the patient file as well. But that's what we're encouraging most of the clinics to go towards, is a secure platform.
Mm.
Does anyone want to unmute and ask any questions, or pop them in the chat and I'll ask? I'm blown away by the consent, because I don't do a lot of skin surgery, but back in the day, I remember it was a hospital doctor, the consent being done by a surgeon in the anaesthetic room whilst the patient was drugged up on their pre-med. And the fact that you're now doing it almost as a separate intervention, a separate appointment than done pre is a significant change. But having seen a lot of doctors going through some pretty traumatic medical legal experience, I think it's definitely something, if I was doing skin work, I'd be really focusing on.
Yeah, I mean, that's the key aspect. It's communication. It's giving the patient time to process what's happening, the risks involved, and that cooling off period. I think that's really important. I'm sure Marianna will agree.
No, definitely. The more the discussion, the more managing patients' expectations, and the documentation will support a claim. But even if we remove the chance of a complaint or a claim, it's also about the patient's outcomes.
Yep.
Colin, can you see the chats, the messages there?
I'm just getting, there's a couple of questions just coming in now. What's the...
By all means, guys, you can open up your mics and ask questions. Marianna's here to join us from Avant, so throw your questions out to her. You'll get a medical legal aspect.
So Justin's from Adelaide here, so he's downloading photos onto the BetterMed, or uploading photos onto the BetterMed email and uploading into best practice. Is that secure?
Well, emails aren't considered secure. It depends on how many photos he's taking, but it's very easy for him to get onto Derm Engine, and I'm more than happy to give him a training on it.
I think it's a much safer option, because whenever you're using another sort of device to try and transfer that information, there is the risk of it not being documented appropriately or in the detail that it should be.
Yeah.
And so Helen's asking a question that's probably more relevant for me as well. Would you use a written consent for Effudix treatment?
I would.
Yeah.
So Effudix treatment can have permanent pigmentation changes. And so anything that can have permanent changes, it's worth discussing the risks, material risks, and going through the consent with them and getting to sign a consent form. Now, as we've mentioned before, it's not the actual consent form, that it's the process of getting their consent. So the patient is very well aware of those risks. But no, anything that has permanent changes, I think it's worth getting a consent form for.
I think the other thing that impressed me is the thoroughness of your consent form. I know my consent forms, there's a lot of, I've kind of assumed consent. And I think that's what you made clear to me today, is that you just can't do that. You have to break it out, isolate it, individually note it. And it's like all our notes, isn't it? What if it's like Marianne said, if it's not in the notes, it's hard to claim that it was done. And I think that's where the consent process is definitely improved.
Yeah, and it's all about risk reduction. Like we've always said, a robust consent form reduces your risk if there is a claim made against you.
Yeah.
As well as if you're giving the patient a copy of that, it gives them information to take away as well and refer to.
Yeah.
And Justin's suggesting maybe lower expectations, tell them there's going to be an ugly scar, and then
telling them that it's going to scar, and worst case, best case, those are the sort of things you need to be telling them.
Emang's asking about Derm Engine in Mackay. I think that's on the way, or?
Yeah, I think that's in the process of being looked at. The IT, Ben Wang's looking into that to see if they can get it up there, but that should be up there soon.
Definitely shouldn't be far away. We'll chase that up tomorrow.
Can I ask a question? It's Mayor here.
Sure, mate.
Hi, I just wanted to ask about the Derm Engine. So with regards to Derm Engine, the photos that I take are on the Derm Engine platform, and in the notes in Better Medical, I just document that I have uploaded the lesions I document which lesions are of concern to me and which ones I've uploaded to Better Medical, to Derm Engine for monitoring, and which I'm going to, any one that I biopsy or excise, I always upload it onto Derm Engine before doing it, so that I have my evidence. So, although I understand that is not necessary, because I understand a lot of doctors will just document that there's a lesion there, document the size, and just go and do it. And that that sort of gives them a lot of leeway of what numbers they state, because they can state numbers which are conducive to the billing item, as opposed to when you have like derm engine and I'm taking an image, dermatoscope image with the scale on it on the dermatoscope, it's telling the exact lesion. It might be that it's like a millimeter short of the next billing item, and when you have derm engine, it's precise data, but while when you're speaking without the photos, you can just mention the suitable item. So that's the one difference I've noticed, that with derm engine, I think there's more work that takes longer to do skin checks and document, and it's good, probably better medically, but I think it's covered anyway, even if you don't use derm engine like photographs to prove the case. A lot of skin doctors don't do that.
I think if you read the Professional Services Review Committee reports, they expect you to have digital photos. If you get audited by APRA, or if you get audited by Medicare, the more evidence you've got of what you've done, the safer it is for you. So, and that's what all the reports generally talk about. I get your point that people do just notate it in the notes, but if you get to the point of ever getting audited, and Marianna would know this much better than I do, if you've got digital photography evidence of what you've done, this is the procedure, this was my margin, this is how I closed the wound, it just holds you up really well under those audits.
Definitely, especially when you have a peer that is reviewing your notes, that's what they would expect to see. And I may have misunderstood part of what you were saying, but was part of your reason for not, that some doctors are not doing it and they're only documenting it because of potential Medicare audits, that if the photo from derm engine is actually demonstrating that it was not quite wide enough and that you charge a different item number? Is that what you were also including, or did I misinterpret that?
So I think that when people are writing down the figures, they make an estimate of it, which is conducive to their billing. While when you use precise measurements, it might be that it's a millimeter short of that billing item that you use, but that's visible on the photography, as opposed to the reality of it is when you document it and you make an estimate when you write it in the notes and you don't take a clinical picture, then in one regard, you have scope for billing a higher item number.
I guess my question to you there, or my alert to you there, I guess, is that if that's one of the reasons, then I think you should question, should I be charging that other item number anyway? Because, Medicare audits can be pretty severe, as if any of you have been involved in them, and particularly if it gets as far as the PSR. I personally don't think that's enough reason not to do it. I think the support and evidence for you, if you are being investigated, whether it be by APRA, by the PSR or whatever, is probably going to be more supportive for you to have that clinical photography. And as Jarrod said, the PSR is expecting to see it. There's been a lot of changes in the PSR over the last few years with this current director. And I think the expectations are much higher now.
I'd also encourage you to download the photos back to the patient record, the patient management software, because it's really important to have a PDF copy in the patient management software of the photos you've taken, because it's all about, again, the continuation of care. You might not be there the next time the patient comes in for a skin problem. It could be the same skin lesion. If it's in the file, then that's very easy for the next doctor to access.
If all the doctors have access to derm engine at the better medical practices, then is it fair enough to leave them in the better medical, the derm engine? If all the practitioners at the practice in better medical have access to the derm engine software, then is it all right to leave the photographs in derm engine?
I think the primary record should always be the patient management software at the clinic. Yeah. So that's got to be the primary record. That has to be the most up to date. And it takes 1 or 2 clicks to download that back into the correspondence.
I think maybe there's been a few questions on the chat around derm engine. It might be worth us maybe setting up another webinar shortly around actually just presenting derm engines. People wanting to know exactly what it is, how it works, and maybe we can do that and see if other people are interested and take this discussion a bit further. Yeah. Tom's asked a question from around, says, I often biopsy during a skin check and waiting to biopsy and follow up would be a big change to my workflow. Sounds like the standard should be to wait. I'm concerned that failing to biopsy and relying on a patient to follow up may open me up to more risk for patients being non-compliant. Any thoughts on that?
Yeah, so Tom, good question. To me, it also depends on what you're looking at. If you've got a patient coming in, you're like, this is a melanoma, 100% this is a melanoma, then I'd be considered doing the biopsy on the day just to confirm that. If it's anything outside of melanoma, then I'd generally get them back. The consent for the risk for a biopsy are very small compared to the risk for formal excisions and other, flaps and grafts and those sort of things. I think the more complex procedure, definitely patients need time. But if you're talking about a short little shave biopsy, I think you probably could talk to the patient at the time and explain the material risks and then get the go ahead. But the more complex procedures, I'd be definitely giving a cooling off period.
And then, thanks, Jarrod. There was just another question there for Marianna around the wording of the letter, the registered letter to patients who can't be contacted. I guess there's some concern there around maybe sending a letter to an address where they haven't responded. I guess that maybe they've moved, and is there any concerns there around patient confidentiality?
If you send a registered letter that is requiring that person to sign that registered letter, you've done all that you can, and you've done as much as you can to actually try and contact that patient to provide that continuity of care, to explain the reasons why they need to come back. But also you've protected that confidentiality as much as you can. You can't control what's going on in the relationship in that house. So you need to err on what your duty is to follow up rather than the risk of breaching confidentiality, because you wouldn't have breached that confidentiality of that patient if you're sending in a registered letter that needs to be signed. But if somebody else in that household has breached what should be happening, that's not on you. And once the registered letter has been sent and documented, that is where your responsibility finishes. There are some incidences where some doctors will ask, how far should I go to when I really think it could be a high risk that there is a melanoma, or indeed that the patient has actually been diagnosed with melanoma and we can't get hold of them. And the answer to that would be, it depends on the clinical issue relating to that patient. And always phone your medical defence organisation to get reassurance about what you should do in that situation if you're not sure. But there has been incidents where doctors have actually gone a bit further when it has been a melanoma or something that's really quite serious, that really does need that patient to come back. And they have actually contacted Medicare. They don't give them clinical information, but they'll ask them to contact that patient, because Medicare and the police will probably be the two entities that have the most recent data on where that patient is. And some have actually got the police involved to try to contact that patient without telling them why.
Yeah, that's good advice. Yeah, I think the minimizing risk and that sort of, even I'd love to see these sort of things being discussed in clinic meetings and everyone being aware of these problems. Final question, I guess, because we're running short of time, but Jarrod, there's one question around what's the maximum cancer size on a torso you would excise or flap?
It depends on the type of skin cancer you're looking at. So if you're looking at a melanoma and it's a relatively big melanoma, if it was greater than 2 centimeters, I'd take it off with a 2 millimeter margin, and then I'd wait for the Breslow before I decided if I did that again. If it's a squamous cell carcinoma that looks thicker than a few millimeters, well, that's going to be a high risk squamous cell carcinoma. So you may want to just do a punch, confirm the depth, and then refer that off. It's all about what you're comfortable with and what you think the patient's comfortable with in terms of managing that wound. Obviously, big skin cancers on the torso require big wounds, and they require people really to look after those wounds if they're going to heal properly. So it always depends on what you're looking at. Yes, Mahou.
Hi, do you have pre-existing form for FUDIX consent? I never had it done in writing, and I've just had a discussion with them about it.
I'll send you one.
Oh, brilliant. Thank you so much.
Which clinic are you from?
Doctors at Eaton's Hill.
Okay, I'll get it there.
Thank you so much.
I think it's been really, thank you very much, Jarrod, for your
That's fine.
presentation, and thank you, Marianna, for your it's been really good tonight. But I think the other thing that's clear from the number of people that signed on for this is that there's definitely a desire to look at skin cancer work a bit more, and I think it's something that we're fortunate to have Jarrod with his background training in, and Derm Engine is relatively new to a lot of the clinics within the group, and there's a few clinics that I think are maybe interested in it. So we'll definitely maybe build up a bit of a series of these over the next few months, and hopefully see a few of your faces again. But thank you very much, both of you. That was excellent.
So that's fine.
Very
The last thing I just want to touch on is when you're talking about margins of skin cancer, it's not, and as I put up on the slide behind you, it's not actually the size that you're cutting out that is considered the margin. It's measuring it with the appropriate margin and then working out the defect size based on these measurements as what you claim to Medicare. So it's one of those things we commonly see is people claim the full size as being the margin, but it's actually this bit here that you need to claim. Good one. Thanks for joining us, guys. This was recorded. It will be up and it will be available the next few weeks. Send me an email if you've got any further questions that we haven't addressed tonight, and I'll pass it on to Marianna as well. Thanks so much for your time, Marianna.
Thank you. Thanks to everybody.
Thank you all.
Bye.
Thanks, guys.
Bye-bye.